Keynote speaker, Professor Antonio de Ieva. Professor de Ieva is a member of Macquarie Neurosurgery. He's Professor of Neurosurgery with expertise in neuro-oncology, pituitary and skull-based surgery, spine surgery, specialising in microneurosurgery and pain treatment. He's a leader in the field of neuroendoscopy and minimally invasive surgery. Professor de Ieva utilises multidisciplinary management of tumours of the central and peripheral nervous system through collaboration with neuroradiologists, neurologists, oculoplastic surgeons, craniomaxillofacial surgeons, radiation oncologists, neuropathologists, and he closely liaises with GPs, neuropsychologists, pain specialists, and nurses. Professor de Ieva's special interests in skull-based surgery include treatment of complex tumours and conditions affecting the cranial nerves, orbits, and craniocervical junction, which also includes non-surgical options such as gamma knife radiosurgery. Professor de Ieva's multidisciplinary expertise extends to awake surgery and neuromonitoring, hydrocephalus, neurotraumatology, traumatic brain and spine injuries, and post-concussion patients. Professor Ieva is a world leader in neuro-oncology research with over 110 peer-reviewed publications and 3 textbooks. He's been awarded International Neurosurgical Research Awards and also the John Mitchell Crouch Fellowship in 2019, which is the most prestigious research award of the Australian College of Surgeons. He leads national and international seminars and workshops teaching neuroanatomy and neurosurgical approaches and is involved in trialling and patenting new surgical devices to benefit patients. So now I'm completely tongue-tied and in awe of your CV. And on that note, over to you, Professor de Ieva.
Thank you so much for your kind presentation and invitation as well. At this point, you should be able to see my slides, I guess. Let me know otherwise. And good. As I said, my name is Antonio de Ieva, and I would like to bring you through a journey towards the foundation of anatomical and computational laboratories that I do. So there is no conflict of interest. And in this journey, I would like to bring you through my passions, which are history of medicine, neuroanatomy, surgery, especially endoscopic surgery, and neuroimaging, especially the one based on new techniques and computational modeling. So we can start with a sentence saying that anatomy to the surgeon is like the sun for our planet. We're talking about anatomy, and as this sentence has been said by one of the most famous neurosurgeons in the world, Robert Spetzler, of course, he also added the neurosurgical part. It gives us the life-sustaining knowledge to traverse the intricate pathways through the brain. But of course, this is translatable to all the kind of surgery. Anatomy means just cut open and dissect, but you can acknowledge that dissection is not just what we do in anatomical understanding. It's not just the cadaver dissection like in the past, but nowadays we can do what we call radio anatomy, which is based on imaging. And nowadays we have a lot of tools to do fantastic rendering also in 3D to see the anatomical structures. So it has been a long journey since the first officially sanctioned dissection in the 13th century in Italy, when you can see the magister here teaching or telling the Berber to do dissections. The categorical imperatives of anatomy is that there is a compulsory laboratory training to acquire expertise in all the avenues of microtechniques. And this sentence has been said by Professor Yajargil, one of the founders of neurosurgery. And I love this sentence by him: the better we see, the more we know. And the more we know, the more we see. So we have to study in order to see and predict what's going on in the anatomical and surgical dissection. Just to link to the previous presentation on retirement, you may know that Professor Yajargil did the last operation when he was 86 years old, and now he's 96. And this is 2 years ago when he was 94, when I reached him for some projects together in Istanbul. And here, 94 years old, every day in the hospital, and here he's dissecting each single word that I wrote in a paper we were working on together. Acknowledging the importance of anatomy, I loved also this sentence: anatomy is the alpha and omega of medical science, where what lies between belongs to clinical medicine. This was said by Professor of Anatomy in Vienna, and I had decided to go when I was a registrar and also a specialist to the University of Vienna, because there was a very good neuroendoscopy lab. And this is the lab where I worked for several years. And in this lab, there was the development and invention of the neuroendoscopy as we know it nowadays. And also neuroendoscopy has been a long journey from the time when Philip Bozzini introduced and invented the endoscope. So this was the Lichtleiter, which was the instrument illuminated by candle light to see inside the human bodies. Of course, big evolution, because nowadays in neuroendoscopy, we don't do just a pituitary surgery like in the past, but basically with endoscopy from the nose, from the mouth, or minimally invasive approaches, we can go everywhere in the brain. So from the nose, for example, we can go all the way in the midline, from the crista galli all the way down to C2. So when I was in the lab many years ago, we tried to put together the aims of endoscopic training in the cadaver lab, which are valid for all the anatomy. And this is a summary, including, for example, the anatomic orientation. It's what I call a syncope. Here there are some examples. The third nerve is always between the posterior cerebral artery and the superior cerebellar artery. Doesn't matter if this is an endoscopic visualization, is a macroscopic, rough macroscopic dissection on cadaver, or is a surgical approach like this approach in which you see the third nerve. The third nerve is always there. So it's just the way you change the orientation and the anatomical approach that gives rise to a different visualization. And this can be just learned in anatomical lab before approaching the patients in the operating theater. You can do also simulation surgery, testing the technical feasibility of an approach. For example, it's not well known that the founder of neurosurgery, Harvey Cushing, before approaching a patient, was always trying and testing the feasibility of an approach on cadavers. For example, he introduced the Gasserian ganglionectomy, and he did this on 30 cadavers before approaching patients. Moreover, the more we know in anatomy, the more we can be predictive. So to follow the Jagergel concept of predictive but not reactive surgery. And we can also learn to do what Professor Chabicher, my supervisor of anatomy, called the minimal traumatizing approach, which is a more advanced than the minimally invasive approach. Sometimes an approach looks minimally invasive, a small incision, but can be maximally traumatizing. So the real goal is a minimal traumatizing to the normal anatomy of the patient. And moreover, we can, in cadaver lab, we can test also different tools like the navigator, robots, and CUSA, and things like that. And again, it's been a long, long journey from the time where the magister was telling to the barber what to do. Here, for example, I'm testing the use of the Da Vinci. As you well know, Da Vinci is very well used in the urology and the general surgery, not so much in neurosurgery. But here, for example, my barber are here, the arms of the robot, which are doing a dissection of the pituitary region in a cadaver. So before doing pituitary surgery, I did a lot of dissection of cadavers. So, and this was very important to give me the manual dexterity and also the anatomical syncope to understand the relationship. Syncope means anatomical relationship. So we put together that the pituitary gland is always here in the center, and we can fill up with our knowledge what is around, what is behind, and so on. So the passion for history of anatomy is not just a coincidence, because many times I was just trying to go back and forth between the knowledge. I saw this book of the 1875, in which for the first time there was a description of the cistern in the brain where the cerebrospinal fluid flows. And I saw this thing that I never realized that was really present in patients in cadavers, what is called the subdiaphragmatic cistern. So I went to the lab trying to look for the subdiaphragmatic cistern. I did anatomical and radioanatomical studies, and this knowledge gave me the characterization of something which is not very well known by neurosurgeon. And this brought me also to understand better what I do when I do skull-based surgery, like in this example, in which basically I was able, in the dissection of a tuberculous cell meningioma, to try to understand how is the anatomy surrounding the pathology, which is in this case the meningioma. And in anatomy, it's also very important to understand the variations. In this endoscopic approach to a skull-based tumor, it would have been difficult to understand what I was dealing with here, because this is a duplication of the anterior communicating artery. But should not be a surprise if you have studied the anatomy and all the variants, because look, these are all the books talking about the anatomical variants. This was well described. And if you study much better the imaging before approaching a patient, you can be more predictive and then reactive, because you know that when you remove the tumor, this is what you are going to find, a duplication, which is anatomical variation. So again, when I was a registrar, I was really puzzled how people, some surgeons could do an approach with a minimal invasive approach in the eyebrow and going basically to the skull base to remove tumors. And I tried this multiple times on cadavers, and indeed, I realized that by means of such a small corridors, you can go everywhere on the skull base. And by the means of this approach here, you can see the optic nerve, the anterior clonidal process, and you can go all the way backwards, even to the prepontine cistern with the basilar artery. And here again, the famous third nerve that I mentioned before. So thanks to this understanding, I was able to translate in the clinical application this knowledge. This is a patient recently done in which the eyebrow approach brought me with a very, very small incision, with a very small craniotomy to the base of the skull. So for sake of time, we can skip some parts of this operation, but you can see that endoscopically, by means of a minimal invasive approach, I was able to remove this skull-based tumor. And here you can see all the normal anatomy with the pituitary stalk. The pituitary gland is here. This is the optic nerve and carotid artery. There is still a bit of a tumor here that I will remove later on. And here is olfactory nerve, frontal lobe, and the carotid artery on the other side. So with by means of a small approach, basically the skull base is reachable. But this is just an example translatable to all the kind of surgery, not just skull-based surgery, of course. And this brought me to summarize when I became professor about neuroanatomy at Medical University of Vienna. I put together a booklet for medical students, but in the neurosurgical perspective, trying to put together all this kind of different information. And this booklet has been used in many universities over the last years. And when I arrived and when I joined Macquarie University a few years ago, when I came to Australia, I started also to put together a small lab where registrars and fellows were able to dissect the brains to try to understand the syncope, the anatomical topographical relationship of the brain, and try to understand better what happens in the surgical approaches. And it's also a nice coincidence that 5 years ago, the RACS invited me to deliver a lecture in Brisbane talking about the online delivery of anatomy teaching. It's something that I was not supporting a lot in that time because I still prefer the cadaver lab dissection. But nowadays in pandemic restriction, I think that is something coming back very, very relevant again. So at Macquarie University, we started to organize the first neuroanatomy workshops in Australia, where for the first time, the white matter dissection technique was taught. We did one in 2018, one in 2019, where we had some registrars, fellows, and a consultant from Australia, New Zealand, overseas. This is the lab at Macquarie University. And I gave some stimuli to go through this anatomical dissection to understand better what we do in our patients. And we did other courses also for microvascular anastomosis or the use of fluorescence in neuro-oncology and so on. And the reason why I was teaching the white matter dissection is because nowadays with the neuroimaging, we can see very well the white matter, and we can use advanced imaging to see the structure that we are crossing through in the brain. So this is a glioma that are resected, but if you can see here, there are advanced computational tools to see the white matter in vivo. So this is the resection of stopping exactly 1 millimeter anterior to the corticospinal tract in order to do a total resection, actually a supramaximal resection, and avoiding any injury on the patient, any plegia. But in these videos, there is also not just the anatomy, but also the functional connectivity, what we call connectomics, how the brain is connected. So here, for example, is a study of the silence network, and here the language. And why? Because we want to know the anatomy and how we interact with that brain in the time we remove the pathology in order to avoid any damage to the patient himself. And this brings me to the second part of the lecture, the fractal brain. As a computational neuroscientist, I also interested in this model, which is called the fractal geometry, and applied it to the study of the brain. So to make the story short, fractal geometry is the geometry of nature, quantifying the complexity of a botanic tree or even a bronchial tree, like in the lungs. And this can be translatable also to the brain, because the brain is full of arborization pattern, like the white matter in the cerebellum, which is called Arborvitae, the tree of life, or the white matter, or the cerebrovascular system in a physiological as well as pathological condition, like an arteriovenous malformations. So I applied the fractal geometry to a lot of different problems, and this is just one example. During my PhD, I was studying glioma microvascularization, and I built up a new mathematical model to automatically classify glioma according to the complexity of the microvessels. And basically, I was able to automatically differentiate the glioma if it was a grade 2, grade 3, or grade 4 glioblastoma according to the WHO classification system. So from the histopathology, I brought this also to neuroimaging, and we introduced the new technique, fractal-based, in which we were able to automatically differentiate if a tumor is a metastasis, is a glioma, is a meningioma, things like that. To make the story short, we did a lot of research on this, and we published a book on the fractal geometry of the brain. But the real take-home message that here we were doing a pattern recognition by using a computational model which was fractal-based. Nowadays, you may know that artificial intelligence is skyrocketing science in general in all the domains. So at the end of the day, what I used in the fractal geometry was already happening also in artificial intelligence. So the next step was simply going towards the application of artificial intelligence tool like deep learning to understand better pathology in order to have a better diagnostic, therapeutic, and prognostic power with our patients. So thanks to the John Mitch Crouch Fellowship in 2019, I was able to found the Computational Neurosurgery Lab, where I put together computational neuroscientists, computer scientists, engineers, and we start to do a lot of, to translate some computational tools in the clinical neurosurgery and neurosciences. Here there are a bunch of examples. Deep learning, which is an artificial intelligence model, has been used to automatically differentiate the different parts of tumors. So the solid part, the necrotic part, the edema. We were able to differentiate what is a progression of a tumor from which is a recurrence, from a pseudo-progression, which is just the response of the brain to radiochemotherapy. Or this is another model that we built up thanks to an NHMRSC grant, in which we were able to automatically differentiate or automatically find an aneurysm on imaging, and also doing some computational fluidodynamic study to understand or to predict or stratify the risk of rupture in patients having a brain aneurysm. Another example is in the computational neuropathology, applying deep learning on a histopathology slide, even not just to know what kind of a tumor is, but even to predict what kind of genetic mutation is there, even before doing the normal standardized genetic testing. Here, for example, we were able to predict the genetic mutation called IDH just by looking at the image by means of a deep learning model. Something we are working now for is a more cognitive neuroscience based, and this is something very recent because I got a couple of years ago an Australian Research Council Future Fellowship, and thanks to this, I put together a machine vision project. What you see here is a brain, and all these colors are eye tracking of a different participant looking at that image in a different way. We are trying to see how expert they look at the image and how we can translate this finding in a machine learning tool for automatic recognition of features in radiology. So where are we aiming to is that nowadays, this is the present, there is a team of different specialists dealing with pathologists, but the future could be augmented by artificial intelligence, because basically this little guy, which is the machine, the computer, could help the MDT to have a better diagnostic power and a better treatment for our patients. So I would like to conclude with this sentence that machines will not replace physicians, but physicians using artificial intelligence will soon replace those not using this. Of course, this is quite a provocative sentence, but the real take-home message is that surgery, neurosurgery, but surgery in general is a very multivariate universe and multidimensional universe. And computational modeling, anatomical training are all things converging towards a better understanding of science, adding some knowledge to the knowledge, and also trying to improve the outcome for our patient. Thank you so much, and I'm ready for some questions, if any.
Thank you very much, Professor De Ieva. I do have some questions for you from the audience, and we'd love some more. First of all, fantastic talk, amazing journey, and we're lucky to have you here in Australia. Do you think with your experience there will be a role for AI in imaging and histology, and how do you get our radiology and oncology colleagues to buy in?
Well, the answer is yes, because all the examples I was bringing in my lecture were about the neuroimaging. So we're talking about the radiologists and neuroradiologists, and the digital pathology. So basically, we use deep learning artificial intelligence in pathology for automatic diagnostic differentiation. Now, there is no challenge at all against radiologists and pathologists. In the past, we were always talking about machine versus expert. And indeed, I don't use the word anymore, artificial intelligence, but AI for me stands for augmented intelligence. So we add the natural expertise of a medical expert with the power of a machine. And that's why I'm talking about the AI augmented MDT of the future. We still have the same expert sitting at the MDT, but we just implement our decision-making by means of the machine. Indeed, we use and we introduce the expertise of a neurosurgeon, pathologist, radiologist in what the machine does. And this is the cooperation between expert and the AI is the future we are aiming to. So there is no competition at all. There will be a perfect integration between all the different specialists.
Thank you very much, Professor De Ieva. I'm just wondering if there's any other questions out there. I certainly loved your quote of anatomy is the alpha and omega of medicine, and I think that goes across all surgical specialties. We have one other question. You talked about the importance of the concept of syncope, and how do you think this is best taught? Still by cadaver or animal, other than in the pandemic? Do you think what resources can we best use for this?
Yeah, I love this question because basically now there is a lot of modeling and some simulation tools to learn anatomy. But unfortunately, in these simulation tools, there are main features, but there are not all the features that we need. So unfortunately, the cadaver dissection is still the best way to understand anatomy and syncope, so the anatomical topographical relationship. Said that, regardless of the pandemic restrictions, still remember that what we do nowadays is not anymore the statistical anatomy, because we can customize the knowledge of anatomy to that specific patient. How? Because the imaging is fantastic. We can do CT scan, MRI, rendering, and we can really understand all the relationship of the topographic anatomy. So there are, for example, fantastic tools. So you can know Ozarix is something that we use for imaging. For example, you open the DICOM images. Ozarix is a very, very good tool to do a rendering of the images, and you can even slice, cut each single 3D images in two-dimensional images in an endoscopic or microscopic way. So you can still learn the topographic anatomy by means of computational tools, software, or different hardware. So it's not just cadaver, although it's the best, of course.
Professor Paul Smith had a similar question about how important, in your view, was in-depth cadaver-based anatomical teaching, and of course, including dissection programs. And should we develop further facilities to pursue this form of teaching?
Yes, of course, has some cost, and it's really demanding. So at the end of the day, creating workshops like the ones we have created in different parts of the world, including Australia, is the best way. Of course, doing a workshop every year is not enough, but at least it triggers the curiosity or understanding of the things we need for the surgical dissection.
Okay, well, if there isn't any more questions, I'd like to thank you very much, Professor de Ieva, for your wonderful talk. Thank you.
Thank you again. Cheers.